The COVID-19 pandemic and the Black Lives Matter movement have exposed the consequences of structural racism. Describing and understanding health inequalities amongst people from racially minoritized groups is now more important than ever. Women living with HIV in the UK are an ethnically diverse group with significant psychosocial challenges. Increasing numbers are reaching older age. However, data on the intersecting effects of gender, HIV, mental health, age, and socioeconomic factors are lacking. In this paper, we investigate the association between ethnicity and socioeconomic factors and ethnicity and mental health among women living with HIV aged 45 to 60 years. We analysed cross-sectional data from the PRIME study. The PRIME study explored the menopause and HIV, an issue that's increasingly important but one that's not had much attention. Conducted between 2016 and 2017, the study recruited 869 women living with HIV aged 45 to 60 across 21 clinics in England. Women completed paper questionnaires capturing data on ethnicity, socioeconomic status, mental health, and social isolation. CD4 count and HIV viral load were obtained from clinical records. Because we wanted a large enough sample size to really understand the effect of ethnicity within this analysis, we limited our sample to women who'd reported their ethnicity as white British, black African, or black Caribbean, which was the majority of the whole PRIME cohort. We had 869 respondents within PRIME, and we included 724 women in this analysis. We used multivariable logistic regression to assess the relationship between ethnicity and a range of psychological and socio-demographic factors within our sample. Importantly, both the PRIME study and this analysis in particular are informed theoretically by the concept of intersectionality. Intersectionality is a framework that seeks to understand how multiple social categories combine and intersect to shape experience and disadvantage. This analysis looks at the intersection between gender, age, ethnicity, and HIV status, and the effect that this can have on women's lives. Even when looking at ethnicity, we recognise that the experience of women who identify as Black Caribbean may differ from the experience of women who identify as Black African, and we attempted to tease this out in the analysis as well. Our results were quite stark. We found a high level of disadvantage within the sample group. Nearly a third were currently unemployed, and around 40% reported not having enough money to meet their basic needs, by which we mean buying essentials such as food, clothing, and housing, despite nearly 2/3 being educated to at least A-level. There were also high levels of psychological distress. Nearly a third had ever been diagnosed with depression, and over a quarter were currently using antidepressants. Around 40% were found to be socially isolated. Ethnicity had a significant impact on these results. Black African women were far more likely to have a university education than white British or Black Caribbean women, but had the same odds of being employed. Both Black African and Black Caribbean women had significantly lower odds of having enough money to meet their basic needs than white British women. Both Black Caribbean women and Black African women had higher odds of social isolation and current psychological distress than white British women. Despite this, Black African women had significantly lower odds of ever having been diagnosed with depression. In this, the largest study to date of psychosocial factors in older women living with HIV in England, we report a high prevalence of poverty, social isolation, and poor mental health. This was worse for women from racially minoritized groups. Despite being more likely to be university educated, Black African women were less likely to have enough money to meet their basic needs than white British women, a likely consequence of structural racism. Despite being more likely to experience psychological distress, Black African women living with HIV were less likely to have been diagnosed with depression than white British women, suggesting that they face barriers to accessing mental health care. This reflects data in their general population. Poor mental health has also been associated in other studies with poor HIV outcomes such as viral rebound. We recommend that HIV clinics take a holistic approach addressing the psychosocial needs of older women living with HIV, which may be more pronounced among those from racially minoritized groups. This includes regular mental health assessment with referral to mental health services if needed, access to peer support, and regular assessment of financial hardship, immigration status, and social isolation. In conclusion, the events of the past year with COVID-19 and the global Black Lives Matter movement have highlighted the effects of racism on health. It is therefore vital, if we want to address racial inequalities effectively, that we establish an evidence base on ethnic disparities in health and well-being among people living with HIV, using an intersectional approach.